I'm just so tired of feeling like this. A friend said I might have peptic ulcer disease, but how do you know?
Peptic ulcers are erosions in the gastroduodenal mucosa related to increased hydrochloric acid concentration, pepsin activity, or decreased mucosal resistance. The back diffusion of hydrochloric acid into the gastric mucosa results in cellular destruction and inflammation. Histamine is released from the damaged mucosa, resulting in vasodilation, increased capillary permeability, and further secretion of acid and pepsin. This damage ranges from superficial to visceral and is strongly associated with H. pylori infection. There are many risk factors for peptic ulcer disease, but few direct causes such as stress and Zollinger-Ellison syndrome.
Symptoms of an ulcer may last for a few days, weeks, or months and may disappear only to reappear, often without an identifiable cause. The symptoms include epigastric or abdominal pain characterized by a dull, gnawing pain or a burning sensation in the stomach or the back. The pain associated with gastric ulcers most commonly occurs immediately after eating, whereas the pain associated with duodenal ulcers most commonly occurs 2 to 3 hours after meals. Some other symptoms include abdominal cramping, heartburn, indigestion, chest pain, nausea, vomiting with or without signs of blood, dark tarry stools, fatigue, and weight loss. Check with your doctor if you experience these symptoms, as diagnostic testing can help determine the cause.
Diagnostic testing for PUD can involve a history, physical examination, upper GI tract X-ray, EGD, serum H. pylori antibody levels, H. pylori breath test, CBC to identify anemia, and stool analysis to identify H. pylori in occult blood. A physical examination may reveal pain, epigastric tenderness, or abdominal distension. Upper endoscopy is the preferred diagnostic procedure because it allows direct visualization of inflammatory changes, ulcers, and lesions that may not be evident on X-ray studies. Through endoscopy, a biopsy of the gastric mucosa and any suspicious lesions can be obtained. H. pylori infection may be determined by endoscopy and histologic examination of a tissue specimen obtained by biopsy, or a rapid urease test of the biopsy specimen. Other less invasive diagnostic measures for detecting H. pylori include serologic testing for antibodies against H. pylori antigen, stool antigen test, and urea breath test. The patient who has a bleeding peptic ulcer may require periodic CBCs to determine the extent of the blood loss and whether or not blood transfusions are advisable. Stools may be tested periodically until they are negative for occult blood. Gastric secretory studies are of value in diagnosing achlorhydria and Zollinger-Ellison syndrome.
So to treat H. pylori, you could use either a triple or quadruple drug therapy regimen. PrevPAC is the triple therapy that includes a proton pump inhibitor like lansoprazole, amoxicillin, and clarithromycin, and the therapy would last about 7 to 14 days, and this is what it looks like. Now, if you're allergic to penicillin, metronidazole is a good substitute. A quadruple drug therapy includes a PPI, proton pump inhibitor, bismuth, and 2 antibiotics, tetracycline and metronidazole, which would last 10 to 14 days. If H. pylori isn't the cause, a single or a combo use of medications, prescription and or over-the-counter, could help. Drug classes like PPIs, like pantoprazole, that reduce gastric acidity and promote ulcer healing. H2 receptor blockers like famotidine and ranitidine that promote ulcer healing, and acids that reduce acid content, and also drugs like sucralfate for short-term use to coat mucosal lining of the esophagus, stomach, and duodenum. Also, be cautious of antacid use in geriatric clients and clients with liver cirrhosis, heart failure, hypertension, and renal disease due to possible drug interactions. Ask the nurse some of the care that you provide to a PUD client, whether it's non-surgical or post-op care, is similar. So you want to reduce the client's anxiety, teach the client to modify some of the foods that he or she eats, like peppers, carbonated beverages, meat extract, broth, caffeinated containing beverages, hot and spicy foods, and you want to reduce or eliminate alcohol. All of these foods can be irritating to the mucosal lining. Client-wise, the nurse would assess any upper abdominal pain, especially epigastric tenderness. You want to know the patient's alcohol and cigarette history, family or personal history of ulcer, disease, liver, or kidney issues, and past or current use of NSAIDs or aspirin. You want to educate the client on meds and what to expect while they're taking them. Unless it's okay by the provider, you want to avoid concurrent use of OTC and prescription medications. You want to take your medications as prescribed and report any signs and symptoms of PUD to the provider. Now, when you have an acute phase of PUD, a client can be NPO unless otherwise ordered, especially if they have an NG tube. You want to provide IV fluid replacement. You want to do oral and nasal care, especially if the NG tube is present. You want to monitor intake and output vital signs and report any abnormalities, and especially hypotension, tachycardia. And you want to report any bleeding, abdominal or back pain, or a rigid board-like abdomen. The most common type of complication of peptic ulcer disease is hemorrhaging. The most lethal is perforation or penetration of the gastric or duodenum when fluids can spill into the peritoneal cavity, causing peritonitis, and the gastric outlet obstruction when over time visible swelling in the abdomen can occur from the stomach. Surgery is a real possibility in severe cases of PUD when clients aren't responding to medications, and they include a partial gastrectomy, vagotomy, which is cutting of the vagus nerve to decrease gastric secretions, and pyloroplasty, which is where you open and widen the lower part of the stomach to the intestines. An acute complication postoperatively is bleeding at the surgical site. Long-term post-op complications from surgeries include dumping syndrome, postprandial hypoglycemia, and bile reflux gastritis,